Every 11 minutes in United States, someone dies by suicide. In 2023, over 49,300 Americans took their own lives, one death every 11 minutes. That's more than double the number of homicides in the same year. But these numbers tell only part of the story. Behind each statistics stands a patient, a family, a clinician faced with one of the medicine's most challenging responsibilities: assessing and preventing suicide. Today we'll explore what clinicians need to know about suicide assessment, from global epidemiology to the specific questions that can save a life. This discussion is particularly crucial for psychiatrists and psychiatric nurse practitioners who face significant professional risk. Patient suicide represents the single most common cause of malpractice litigation in psychiatry. Understanding how to properly assess, document, and intervene can mean the difference between life and death, and between competent care and professional liability. Let's start with a global picture. Worldwide, approximately 717,000 people die by suicide each year. That's 9.1 deaths per 100,000 population globally. But these rates vary dramatically by country. The three countries with the highest suicide rates per 100,000 population are Greenland with 75.6, Suriname at 28.7, and South Korea at 28.1. For perspective, the United States ranks 30th globally with a rate of 15.3 per 100,000 in 2023, right in the middle alongside countries like Nepal, Kazakhstan, and Serbia. What about the United States specifically? The numbers are sobering. In 2023, suicide was the 11th leading cause of death overall, claiming 49,316 lives. But look closer at the age group. Suicide becomes the second leading cause of death for individuals aged 10 to 34, and the fourth leading cause of death for those 35 to 44. Among adolescents and young adults, suicide kills more people than homicides, car accidents, and most diseases. The 2024 data shows a slight decrease to approximately 48,800 deaths, a small but potentially hopeful trend after nearly 2 decades of increases. Whether this represents a sustained decline or a temporary fluctuation remains to be seen. Now, these are completed suicides. But what about attempts? In 2021, emergency departments recorded approximately 148.2 non-fatal self-harm visits per 100,000 people. The CDC estimates roughly 35 suicide attempts occur for every completed suicide in adults. In 2024, approximately 2.2 million adults attempted suicide, and an estimated 14.3 million adults, that's 5.5% of the adult population, reported having serious thoughts of suicide. Among adolescents aged 12 to 17, the numbers are even more concerning. 2.6 million, that means 10.1%, had serious thoughts of suicide in the past year. 1.2 million made a plan, and 700,000 actually attempted. For high school students, 20% seriously considered suicide in 2023, and 10% actually attempted. And what about those who think about suicide but don't have a specific plan? Based on 2024 national survey data, 5.5% of adults had serious thoughts of suicide. Among young adults aged 18 to 25, the number jumps to 12.6%. Most concerning among LGBTQ plus youth aged 13 to 24, 3.9% seriously considered suicide in the past year. These aren't just statistics. They are our patients, our neighbors, our children. Now, let's address something many clinicians worry about, but few openly discuss: malpractice liability. The reality is pretty worrisome. Patient suicide is the number one cause of malpractice claims in psychiatry. Data from prominent psychiatric malpractice insurer covering 30 years of claims shows that suicide or attempted suicide represents the most common trigger for litigation, closely followed by claims of incorrect treatment. When these cases go to court, the average settlement for all medical malpractice cases hovers around 425,000, but jury awards average over 1 million, more than double settlement amounts. For psychiatry, specifically, suicide-related malpractice cases have resulted in verdicts ranging from 100,000 to over 8 million, with settlements varying widely based on circumstances. One particularly instructive case, an Oklahoma jury awarded 8.008 million after a physician failed to conduct an adequate psychiatric evaluation and missed terminal insomnia, a red flag for depression leading to a murder-suicide. The family contended this was the sole proximate cause. For psychiatric nurse practitioners, the liability landscape is similar. A notable case involved a psychiatric nurse practitioner who prescribed an SSRI without adequate warning about suicide risk or monitoring the patient, resulting in a suicide. The case highlighted failures in suicide risk assessment and informed consent. The message is clear. Proper suicide assessment isn't just good clinical care, it's essential risk management. The courts will examine four elements: duty, dereliction of duty, damages, and direct causation. The issue often turns on foreseeability. What was known or should have been known about suicide risk? And was the assessment reasonable compared to what other practitioners would have done? Documentation is your shield. Contemporaneous, systematic suicide risk assessment combined with appropriate interventions provide the best defense. We'll discuss exactly what that documentation should include. Not all psychiatric diagnoses carry equal suicide risk. Understanding which patients face the highest danger is fundamental. Proper assessment. A landmark study examining 2,674 suicide cases found that having any diagnosed mental health condition increased the suicide risk nearly sevenfold compared with the general population. But specific diagnoses carry vastly different risk levels. The psychiatric diagnosis with the highest suicide risk ranked by adjusted odds ratio. First, schizophrenia spectrum disorder, 15-fold increased risk. These patients die by suicide at 15 times the rate of those without mental health conditions. Interestingly, the risk is highest among young adults aged 18 to 34 with schizophrenia, the opposite pattern from the general population, where older adults have higher rates. Second, bipolar disorder, 13-fold increased risk. At least 25 to 50% of the patients with bipolar disorder attempted suicide at least once in their lifetime. The risk is particularly acute during depressive episodes, mixed states, and in early years after diagnosis. Patients with rapid cycling and those with comorbid substance use disorders face even a higher risk. Third, personality disorders, 7.7-fold increased risk, particularly borderline personality disorder, where chronic suicidality is often a core feature. Fourth, major depressive disorder, 7.2-fold increased risk. Half of all suicide deaths occur in people with major depression. When depression co-occurs with other conditions, particularly substance use disorders, risk multiplies exponentially. Fifth, obsessive compulsive disorder, 4.7-fold increased risk, often overlooked but significant. Sixth, substance use disorder, 4.5-fold. Alcohol use disorder alone carries 4.4-fold increased risk. Substance use is the second most common risk factor after major depression. Additional high-risk conditions, anxiety disorders, 5.8-fold, PTSD, 3.4-fold, ADHD, 2.4-fold, eating disorders, and autistic spectrum disorder all show elevated risk. But here is what every clinician needs to know. Comorbidity dramatically amplifies risk. A patient with depression and alcohol disorder faces far higher risk than either conditions alone. Add chronic pain, recent psychosocial stressors, prior suicide attempts, and access to firearms, and you are looking at a perfect storm. The prototypical high-risk patients, a young adult male with bipolar disorder or schizophrenia, comorbid substance use, recent psychiatric hospitalization or discharge, prior suicide attempts, recent severe stressors, social isolation, access to lethal means, and impulsivity. But suicide doesn't discriminate. It can happen to anyone with sufficient risk factors and acute distress. Now we arrive at the critical question: how do you actually assess suicide risk? What must be checked when a patient talks about suicide? A proper suicide assessment is systematic, thorough, and documented. Think of it as having several essential components. First, current suicidal ideation. Don't dance around it. Ask directly: are you having thoughts of ending your life? Research consistently shows that asking about suicide does not plant the idea, it opens the door for help. Then drill down. Frequency. How often do these thoughts occur? Duration. How long do they last? Intensity. On a scale of 0 to 10, how strong are they? Controllability. Can you dismiss them or are they intrusive? Second, intent or plan. This is where risk stratification becomes clear. Do you have intent to act on these thoughts? Have you made a plan? When, where, how? Have you done anything in preparation? Acquiring means, writing notes, giving away possessions, putting affairs in order. Have you rehearsed or practiced? The Columbia Suicide Severity Rating Scale provides an excellent framework distinguishing between wish to be dead, passive ideation, suicidal thoughts, thoughts with methods, intent without plan, intent with specific plan. Third, access to means, the most critical question that's often overlooked. Do you have access to firearms? 55% of suicide deaths involve firearms, and firearms are by far the most lethal method. A patient with a loaded gun at home and active suicidal ideation is an imminent danger. You must assess firearms in the home, medication stockpiled, other lethal means available, and crucially, can these means be removed or restricted during the crisis period? Fourth, history of suicidal behavior. Past suicide attempts are among the strongest predictors of future attempts and completion. Any previous attempts? When? Method? Medical severity? Previous psychiatric hospitalization for suicidality? Family history of suicide or attempts? History of non-suicidal self-injury? Fifth, protective factors. What reasons does the patient have for living? Responsibilities to children and family, religious beliefs, fear of death or suicide, plans for the future, quality of social support, engagement in treatment. But a critical note: protective factors do not eliminate the risk in the presence of active suicidation with intent and plan. They inform treatment planning but don't negate the need for intervention. 6. Psychiatric symptoms and diagnosis. Current episode: depression, psychosis, anxiety, agitation. Substance use: what, how much, when last used. Recent changes in symptoms or functioning. Comment hallucinations telling people to harm themselves. Hopelessness, one of the strongest predictors. Anhedonia, severe insomnia, panic attacks. Seventh, psychosocial stressors. Recent or ongoing stressor can precipitate crisis, relationship loss or conflict, financial problems, legal problems, job loss, chronic illness or recent diagnosis, anniversary of a traumatic event or loss, social isolation and loneliness. Eighth, risk and warning signs. Specific warning signs that suggest imminent risk. Talking about wanting to die or killing oneself. Looking for ways to kill oneself. Talking about feeling hopeless or having no purpose. Talking about feeling trapped in an unbearable pain. Talking about being a burden to others. Increasing substance use. Acting anxious, agitated, or reckless. sleeping too little or too much, withdrawing or feeling isolated, showing rage or seeking revenge, displaying extreme mood swings. The mnemonic is path warm. Can help remember a key warning sign. So is path warm is the mnemonic. What does it stand for? I for ideation, S for substance abuse, P for purposelessness, A for anxiety, T for trapped, H for hopelessness, W for withdrawal, A for anger, R for recklessness, and M for mood changes. Documentation is paramount. Your assessment notes should include specific questions asked and patient's response, mental status examination and findings, risk factors identified, protective factors present, your clinical formulation of risk level, interventions implemented, safety planning, follow-up plan, consultation with colleagues if indicated. A documented phrase like patient denies suicidal ideation is inadequate and legally dangerous. You need patient was directly asked about thoughts of harming or killing himself. He reports intermittent thoughts or wishing he were dead over the past week, occurring daily, lasting minutes without specific plan or intent. He denies access to firearms. Protective factors include responsibility to young children and strong family support. He agrees to safety plan and follow up in 24 hours. Once you've completed your assessment, you need to stratify risk and implement appropriate interventions. Risk assessment isn't a crystal ball. It's about probability and clinical judgment. No tool perfectly predicts suicide, but systematic assessment guides intervention intensity. Low risk characteristics. Suicidal ideation without plan or intent. No recent attempts, good protective factors, no substance abuse, willing to engage in treatment. Interventions. Outpatient treatment with close follow-up within 1 to 2 weeks. Safety planning with patient and family. Address modifiable risk factors, depression, substance use. Ensure continuity of care. Provide crisis hotline numbers, 988 suicide and crisis lifeline. Document thoroughly. Moderate risk, characteristic suicidal ideation with some intent but no specific plan or preparatory behavior, or passive ideation with significant risk factors, some protective factors present, past attempts not recent, may have substance use. Interventions. Intensive outpatient treatment or partial hospitalization. Very close follow-up within 48 to 72 hours, then weekly. Enhanced safety planning involve family or supports. Means restriction. Remove firearms. Limit access to medication. Consider medication review and optimization. Daily check-ins by phone. Possible contract for safety, though evidence is weak that this can prevent suicide. Clear crisis plan if thoughts worsen. Low threshold for hospitalization if risk increases. High risk characteristics, suicidal ideation with specific plan and intent, preparatory behavior, recent attempt, severe psychiatric symptoms, comments, hallucination, severe hopelessness, impulsivity, substance intoxication, absence of protective factors, refusal of help. Interventions, psychiatric hospitalizations, voluntary patients agrees, involuntary if necessary. Emergency department evaluation if not already there. One-to-one observation, remove all potential means, initiate or optimize psychiatric medications, ECT for severe treatment-resistant depression with acute suicidality, consider IV ketamine for rapid reduction of suicidal ideation, family notification and involvement, no discharge until risk substantially reduced, detailed safety plan for discharge, very close follow-up within 24 to 48 hours after discharge. Imminent risk. This is a patient who requires immediate action. They are actively planning to end their lives tonight or have means and are about to act. Interventions. Do not leave patients alone. Call emergency services, 911. If in outpatient setting, psychiatric hospitalization, likely involuntary, emergency department if not already admitted, continuous observation, medical evaluation if recent attempt, Consider emergency medication, benzodiazepine for acute agitation, though caution given suicide risk. Critical high-risk periods. Certain times carry exceptionally high risk requiring vigilance. First week after psychiatric hospital discharge, risk increases 100-fold immediately post-discharge. First week after psychiatric hospital admission, after starting an antidepressant, particularly the first 2 weeks, activation syndrome can be a problem. During medication changes, after a significant loss of rejection, anniversaries of traumatic events. Now, let's discuss a crucial question. Are there medications specifically effective against suicidal ideation? The answer is depends. Most psychiatric medications treat underlying conditions, depression, psychosis, mood instability, which indirectly reduces suicide risk. But only few medications have demonstrated specific anti-suicidal effects. Lithium, the golden standard for chronic suicide prevention in mood disorders. Multiple meta-analyses show lithium reduces suicide risk by approximately 87% in patients with bipolar disorder and major depression. This is a dramatic effect, bringing suicide risk nearly down to general population level. Lithium's anti-suicidal effect appears to work through multiple mechanisms, treating the underlying mood disorder, reducing impulsivity and aggression, and possibly through direct neuroprotective effects. The challenge is that lithium has a narrow therapeutic window, significant side effect profile, thyroid dysfunction, kidney problems, tremors, and requires regular monitoring. Many clinicians are reluctant to prescribe it, leading to underutilization despite clear evidence. Bottom line is, for patients with bipolar disorder or recurrent major depression at high suicide risk, lithium should be strongly considered. Clozapine, the only FDA-approved medication specifically for suicide prevention. The landmark Intercept trial showed clozapine significantly reduces suicide attempts and deaths in patients with schizophrenia or schizoaffective disorder. The effect is robust and dose-dependent. Clozapine is reserved for treatment-resistant schizophrenia due to risk of agranulocytosis, requiring weekly, bi-weekly, or monthly blood monitoring. But for patients with schizophrenia and recurrent suicidality, it can be life-saving. The anti-suicidal effect likely comes from superior control of psychotic symptoms, reduction of impulsivity, and perhaps the increased clinical monitoring inherent in clozapine treatment. Ketamine, the rapid-acting intervention for acute suicidal crisis. Intravenous ketamine, 0.5 mg per kg over 40 minutes, has shown remarkable ability to reduce suicidal ideation within hours, not weeks, like traditional antidepressants. Effects typically last several days to a week. This makes ketamine potentially invaluable for acute suicidal crisis in major depression. It's being used increasingly in emergency departments and inpatient units. The intranasal formulation, esketamine or Spravato, is FDA approved for treatment-resistant depression but shows somewhat less robust anti-suicidal effects than IV ketamine. It requires administration in certified healthcare settings within 2 hours post-administration monitoring due to dissociation and abuse potential. Limitations. Effects are temporary, long-term efficacy unknown, risk of dissociation and potential for abuse. Ketamine is best viewed as a bridge, buying time while other medications take effect. Antidepressants. Complex relationship with suicide risk. SSRIs and other antidepressants carry an FDA black box warning about increasing suicidal ideation in children, adolescents, and young adults under 25 years of age, particularly in the first few weeks of treatment. This is the activation syndrome, increased energy before mood improves, potentially providing the impetus to act on suicidal ideation. However, meta-analysis show that in adults with depression, antidepressants reduce overall risk of suicide. either ideation and behavior. The key is to close monitoring during the first 2 to 4 weeks, especially in younger patients. Never start an antidepressant in a highly suicidal patient without additional safety measures. Close follow-up, safety planning, sometimes hospitalization. Other considerations. Benzodiazepines are sometimes used for acute agitation in suicidal patients, but carry their own suicide risk, particularly in substance users. Use judiciously. Substance abuse treatment is critical. Alcohol and drug use disorders dramatically increase suicide risk. ECT remains highly effective for severe depression with active suicidality, working faster than medications. Let's bring this together. Suicide assessment is both an art and a science. It requires systematic evaluation, clinical judgment, thorough documentation, and appropriate intervention. The numbers we discussed at the beginning, over 49,000 deaths per year in the United States alone, represents 49,000 opportunities for intervention that were missed or unsuccessful, but they also represent hundreds of thousands of successful interventions that prevented tragedy. Every clinician will encounter suicidal patients. Some of those patients will die by suicide despite our best efforts. Suicide is not always preventable, but many deaths can be prevented through careful assessment, evidence-based treatment, and comprehensive safety planning. The key principles to remember. 1. Take every expression of suicidal thoughts seriously. Ask directly and specifically about ideation, intent, plan, and means. 2. Understand that certain diagnoses, schizophrenia, bipolar disorder, major depression, personality disorders carry dramatically elevated risk. Know your highest risk patients. 3. Document thoroughly. Your assessment notes may save a life or protect you in litigation or both. 4. Match intervention intensity to risk level. High-risk patients need hospitalization. Moderate-risk patients need intensive outpatient care. Low-risk patients need close follow-up and safety planning. 5. Use evidence-based medications when appropriate. Lithium for mood disorders, clozapine for schizophrenia with suicidality, ketamine for acute crisis. Antidepressants with close monitoring are an option as well. 6. Remove access to lethal means, firearms, in the home of a suicidal patient represent an imminent danger. 7. Involve family and supports. Suicide prevention is a team effort. 8. The highest risk periods are immediately after a hospital discharge, early in antidepressant treatment, and during times of acute stress or loss. Intensify monitoring during these windows. Suicide assessment is one of the most challenging clinical tasks in psychiatry. It demands vigilance, courage to ask difficult questions, willingness to hospitalize against patients' wishes when necessary, and humility in recognizing that we cannot always prevent tragedy. But with systematic assessment, appropriate intervention, and evidence-based treatment, we can save lives. The 988 Suicide Crisis Lifeline has connected millions with help, improved screening in the VA hospital, and has shown promise. The slight decrease in 2024 suicides suggests our efforts may be making a difference. For those in crisis, 988 is available 24/7. For clinicians, when in doubt, consult. When seriously concerned, hospitalize. Document carefully, intervene appropriately, and never let concern about litigation prevent you from taking the necessary action to protect a life.